So the important motivating background information about this is that depression is not only is it just a huge problem and just a huge social problem, but it's also a particular problem as a risk factor for acute coronary syndrome. And I know not everyone here is clinical, so I'll be using the term ACS, which basically means a heart attack. That's basically what we're talking about. And not only is it a risk factor for development of heart attacks, but it's also common after people have heart attacks. So it's sort of this compounding problem. And in fact, it's very prevalent in patients who have heart attacks. As many as 2 in 5 have depressive symptoms. And these patients have worse outcomes. The mechanisms are still being elucidated, but some hypotheses include poor adherence to medications, which certainly would impact outcomes. And I've also read hypotheses about decreased physical activity in patients who are depressed and have had heart attacks. The bottom line, though, is the same, that these patients have an increased risk of recurrent acute coronary syndrome and death. So a few clinical trials have examined the impact of depression treatment in patients with acute coronary syndrome. There are 2 that I'll highlight. One is the enriched trial. So this was, the PI here was at Harvard, and this enrolled somewhere between 2,000 and 3,000 patients. And what they found really was not very impressive. So they didn't find much, actually, in terms of how depressive symptoms were with treatment between intervention and control patients. And they did find any difference in mortality. I'll talk about why that might be in a moment. Another trial was the MINDED trial. This was a much smaller trial. And again, this trial found improvements in depression in patients with acute coronary syndrome, but no difference in cardiac event rates. So some of the major weaknesses, and I'll highlight the first one in particular, is heterogeneity in the populations. So it's very common for people to be depressed initially when you sort of see them and meet criteria for depressive symptoms initially when you see them in the hospital when they've had a heart attack. But sort of checking on them 2-3 months later, they're doing better. They're no longer having depressive symptoms. And the first trial actually randomized people on the day of hospitalization. So there was a lot of this kind of washout effect from essentially treating non-depressed people. Another problem, and this might be more highlighted in the MINDED trial, was suboptimal approaches to depression treatment. So Karina tried to address this with her COPES trial. So it's the Coronary Psychosocial Evaluation Studies trial. It's funded by NHLBI. And they published their results last year in Archives of Internal Medicine. And what they did was target at-risk patients, by using a 3-month run-in period. So they identified patients who were depressed at baseline, sort of essentially during their hospital stay, and then sort of checked on them 3 months later to identify people who were still depressed. So these are, this is really the population that you're interested in. And they used a very evidence-based approach to depression treatment. So it included components like patient-determined care. So in other words, patients had the choice to choose between pharmacotherapy and counseling, or the combination of them. And it also included stepped care for poor responders. So patients who weren't responding to depressive treatments had sort of escalation of care. It was a very evidence-based approach to treatment. And just as an overview of the study, so there are actually more patients in this kind of, I'm starting here essentially at the 3-month time period, so after we've sort of filtered out all the people who are not depressed. The instrument they used was the Beck Depression Inventory. It's a survey commonly used to assess depressive symptoms. So they randomized 157 patients in the New York and kind of New England area to their intervention, their study intervention, or usual care, which basically consisted of letting the primary care doctor know that their patient had depressive symptoms. And even in the intervention group, not every patient actually received the intervention, and then there was some loss to follow-up in both groups. Finally, the study had a 6-month follow-up period, so the numbers will look a little funny, but it's sort of 6 months after baseline, so it's at month 9. patient characteristics at baseline, the groups were balanced. So you see an overrepresentation of females. So normally probably 80% of patients who have acute coronary syndrome in the hospital are men. We have an overrepresentation of females here. Average age is around 60. And it's quite a relatively diverse population, which actually reflects probably the communities, the hospitals that from which these patients were enrolled. So 44% are Hispanic, between 16 and 20% are African American. This is the BDI score, and essentially a score greater than 10 is indicative of depressive symptoms. And a substantial 1 in 3 patients actually met criteria for major depressive disorder. So this is really an appropriate population for this type of intervention. And then in terms of the type of acute coronary syndrome, so it was dominated by patients who had unstable angina, which is also a heart attack, but not as severe as a non-ST elevation MI or an ST elevation MI. So clinical terms, but essentially everyone had a heart attack. And in terms of results, so the primary outcome was improvement of depressive symptoms. And also patients' experience of feeling like their care was improved in terms of their depression. So the study found that patients were indeed happier with their care in the intervention group. But there was also the secondary outcome that they purposely tried not to overemphasize in the paper, in their manuscript, but is sort of a wonderful outcome if in fact it can be replicated, which is that there was a reduction in major adverse cardiovascular events, which are heart attacks and all-cause mortality. So the combination of those was reduced. So that should have, please feel free to interrupt, ask questions. So from my perspective, I think that coronary heart disease is a great disease to think about cost-effectiveness analysis. So there's an enormous burden of illness. So many patients, so many people in this country and around the world have coronary heart disease. It's responsible for most deaths, the plurality of deaths each year. We've already talked about how depression magnifies this risk. And finally, in coronary heart disease, potentially more than in any other disease, there are just so many different interventions to think about, to consider implementing. So there's a myriad smoking cessation interventions, there are medication adherence interventions. Nitish Chowdhury a few weeks ago published a randomized controlled trial in New England Journal of Medicine looking at basically giving free drugs to patients who had heart disease to see who had heart attacks to see if they improved outcomes. So there's really a plethora of different choices in this population for intervention, and there's so many patients who have this problem. And there's also some evidence that decision makers, that health insurers and payers think about costs and cost effectiveness analyses in surveys. So just to give very brief background, so cost effectiveness analysis is a way of essentially comparing to relative value of different decisions. That's the way I like to think about it. In terms of the cost part, we think about economic costs. So we're interested in resource utilization or opportunity costs, which are synonymous. And then the quality adjusted life here is really the standard for thinking about outcomes, though we could use anything we wanted. It integrates quantity of life and quality of life and uses a utility which is usually in a range of 0 to 1, where 0 is death and 1 is perfect health. And finally, the product of utility and duration is the quality adjusted life here. So this is just a graphical depiction of how one might think about qualities over time with a group of patients who were a patient who didn't have an intervention, a patient who did have an intervention. You consider the value of the intervention being the area, the difference in area between those two curves. And finally, the cost effectiveness ratio is the quotient of the difference between the cost of the new policy and the cost of the current policy, and the effectiveness of the new policy and the effectiveness of the current policy. So turning back to COPES, our sources of healthcare utilization in this study are essentially consists of outpatient appointments, cardiologists, primary care doctors, mental health providers, hospitalizations for acute coronary syndrome and other cardiac conditions, and medications. So in this particular study, there was a big focus on prescribing, in the intervention group, on prescribing different antidepressants for patients.
Did you track other hospitalizations?
Yeah, so we'll talk about that a little bit. So they did, and there are data on other hospitalizations that aren't great. So I'll talk about how I'm approaching that.
Yeah, I was wondering about major depressive disorder lands you into the psych ward or something.
That's a good point. That hasn't been something that's come up in conversation, so
The
hopefully
sample size might be too small too to really.
Yeah, that's a good point.
Joe?
Yes.
Why did you look at mental health visits in the intervention group only, given that there was a lot of depression in the control group?
Yeah.
And I wonder if there might actually be more mental health visits later on if the depression isn't dealt with in a proactive way.
Absolutely, Scott. So some of what you'll see here is by theory, and some is by design. So we were restricted in terms of what we had available to us because of design of the study. In this particular, I should say that the outpatient visits include mental health visits here.
Okay.
But the intervention group, because the intervention was built around a sort of a combination of pharmacotherapy and psychotherapy, there was a pre-specified plan for mental health visits. And indeed, those were actually more accurately recorded. And we use standard costing methods. So for outpatient appointments of all varieties, we use CPT codes and Medicare reimbursement rates. For hospitalizations, we only tracked acute coronary syndrome, and it relates to the question that Heather just asked, and it really has to do with the fact that we just didn't have very great reliable data on non-ACS, non-acute coronary syndrome hospitalizations. So that's based on DRGs and Medicare reimbursement. I'm still waiting on some details on the actual acute coronary syndrome episodes. And for medications, we used average wholesale prices from the Red Book. So this is for things like fluoxetine, which is Prozac, paroxetine, which is Paxil, and really all sorts of different antidepressant medications.
So how were the first two tracked, actually?
Great. So let me just see what the next slide is, because it might relate to that. Well, it kind of does relate to that. So they were actually tracked differently in different groups. So the study surveyed patients at baseline and every 2 months up to 6 months. So those data are homogeneous between the groups. So there were questions about, have you seen a mental health provider? Unfortunately, one of the limitations of the data we have from the study is that we don't have good data on the number of appointments. So we only have binary data for both groups. In terms of mental health visits, we have count data, so we know how many mental health visits patients in the intervention group partook in. But we do not have number of visit data for both groups.
And then hospitalization was similarly every 2 months were you hospitalized?
That's right. And those were fortunately adjudicated. So what was done there is essentially attention was only paid to acute coronary syndrome hospitalizations, which is also part of the reason why that's the focus of hospitalizations.
Other hospitalizations? I mean, just in order to adjudicate them?
Yeah, they did, but sort of the cause, in terms of costing those hospitalizations, it would be hard to know because what the hospitalization was for was not something that was initially sort of obtained. It was more, the question really was it related to acute coronary syndrome or not? And if not, the information was discarded. Mark had.
Hi, Joe. I had a question about the calculation of Medicare reimbursement. And I'm asking because I'm curious in this study, but also I realize I'm not sure how it's generally done and make the cost estimates. Medicare has sort of a generic cost formula, but then it all gets adjusted in a variety of ways based on geographical location, whether it's a teaching hospital or not, whether it's an MD or a non-MD performing the service. In this study and in general perhaps, are those accounted for? Or when you say you're using Medicare reimbursement rates based on CPT codes, is it the crude number?
It's a great question, Mark. So, so for the CPT codes, we use a national reimbursement rates. So Medicare has the number of RVUs that they assign to an appointment with a primary care doctor or a psychotherapy appointment, and we just multiply that by the payment rate per RVU that Medicare publishes.
So there's a trade-off for it's more generalizable.
Exactly.
Perhaps,
Exactly. Yeah.
Ironically, perhaps less accurate for the site that you're studying.
That's totally correct. So in fact, that's actually a good point. I should probably highlight that. So the objective of the cost was to make them as generalizable as possible, whereas the effectiveness stuff is really at the patient. It's sort of very specialized for the patient. And then in terms of DRGs, a similar approach was done. I actually used an estimate that I had from another study, so I didn't sort of re-review my DRG estimation algorithm, but certainly the theme is similar.
So the bias, if there is one, would be that you're underestimating the cost as a result, because generally the cost adjustments increase the reimbursement. Right?
That's almost certainly the case in New England. Just because the rates here, the reimbursement, sort of the geographic correction is higher,
right.
Certainly in New York, without question. So, but and again, it gets to the point that what I was sort of going for here was more generalizability than actually the difference between reimbursement in New York City or reimbursement in New Haven, I think, which is where one of the hospitals was. Hey, Leo.
Hey, Joe, thanks. Just a question related to Mark's question, and there's a little bit of pediatrician ignorance in here, but the way I think about depression is it would complicate coronary syndrome. Might not just be that it leads to coronary syndrome, but it might lengthen the hospital stay for an individual ACS patient, potentially, in that it's a more severe case, all things considered. Yet that's not, the DRG, as I understand it, just bundles the payment based upon a case definition. So I guess I'm just intellectually curious that to some degree you're taking away some of the incremental costs between the two groups, and maybe there might be a cost offset, if you will, that you're missing in the cost effectiveness analysis.
No, this is definitely true, Leo. And in fact, there are data. We actually have data on length of stay because the hospitalizations were adjudicated. We went back and looked at how many days. So you could imagine we could even estimate the cost for these hospitalizations even more accurately. I think I sort of went back and forth mentally. I mean, it's definitely to the extent that potentially the intervention affects length of stay beyond just affecting the risk of hospitalizations, we'd be missing that. And I think it's worth thinking about and worth talking about whether it's worth sort of including more rigorously. Thanks. So we talked about some of these already. I'm just going to take a look here to see if there's anything else we missed. I mean, one weakness, of course, is there was no closed healthcare system, so there's some care that we're not going to account for. Beyond the fact that even outpatient care was categorical and not continuous, not count data. And we talked about most of this. So one approach that I'm sort of thinking about considering seriously to address this issue, because it's actually a really important problem, the fact that we know whether you went to see your doctor, but we don't know how many times you went to see your doctor. I think it's a really important issue, particularly for this population, for this type of intervention. So we do have, the one site that we still have access to data is New York Presbyterian Hospital. Unfortunately, that's only 16 patients, but my feeling is that that's better than nothing. So we'll be generalizing, we'll be using data from this 10% sample of the population to make inferences about what utilization was like for patients who said that they saw a doctor. So, and then in terms of the non-acute coronary syndrome hospitalizations that Heather brought up earlier, we're planning on assuming that there's no difference in non-ACS hospitalizations.
Do you know anything about differences between how a patient's at New York Pres and the other hospitals? Just because
Yeah.
it could be better than nothing, but it also could be worse.
It could be worse. It could be
Right?
worse.
So you want to be very, very, very careful, of course.
No, that's a good
You
point.
will
I
be,
think
but the 16 participants is.
Yeah, that's a good point. I think we'll formally test the characteristics of the New York Presby patients to ensure that it doesn't,
Like
at least
the
the
other
face
ones.
appear right. So that's a great point.
And then, even not just the patients, but the hospitals themselves, and differences between, I don't know if there's, I don't know, but if there's
Yeah,
a
yeah.
differences, just because it could be worse than nothing.
That's a good point. That's a good point. That's a really great point. You know, in terms of the quality of life data, so all patients were given the short form 12. So this is a great little instrument. So here's what it looks like. So it's 2 pages, 7 questions. The SF-12, it's called 12 because though there are 7 questions, there are actually 12 things to respond to. And you can see what kind of questions you have here. So in general, would you say your health is excellent, very good, good, fair, or poor? There are questions here about how much, have you had any of the following problems with your work or other regular daily activities because of your physical health? You know, how often have you accomplished less than you would like, or limited kind of work? So a very simple instrument, and a lot of theory behind it. Rand first developed sort of I think it was called the Rand 36. It was the first version of this. And there have been multiple iterations of this survey. But it's a great instrument. It has excellent properties, and it can also be used to calculate utilities. So that 0 to 1 scale that we talked about earlier. That's a distinguishing characteristic of this that you can't do with the Beck Depression Inventory, for example. So these data were available at baseline and 6 months later. So as I mentioned, you can convert SF-12 responses to utilities. And there's a published regression equation to do this by John Brazier that's based on preferences of a United Kingdom population. So it is based on a non-American population, but no American population has been used to sort of estimate. I know Jan's like, how could that be? You know, I mentioned that there might be some sort of political issues, and this comes from, there's sort of the story, like, for example, I'm friends with a woman named Janelle Hanmer, who has published papers with different utility instruments and has done this sort of thing where she's taken U.S. preferences and used them to estimate or compare different utility instruments, this sort of work. And she's run into trouble with the, I can't remember his name, but there's a company that provides materials for the SF-12 and SF-12 and SF-36, et cetera, et cetera, et cetera. And they've actually forced her to pull down some of the equations that she's posted online. So I don't know whether they're sort of copy. I'm not sure whether they're kind of intellectual property right issues and whether that. Pardon?
It's a cash cow for John Ware.
Yeah.
The whole SF.
Yeah. So
forget what the name
but
of the company.
that doesn't seem to be a good reason not to expand it to obtain preferences from the U.S. population.
Just a weird tangent. The
Yeah.
normal distribution for the platelet count is determined by employees of the Coulter Counter Company in Miami. The company that makes the machine samples its employees, and that's the distribution that gets sent out. Just for instance.
Wow.
Wow. That's great.
All right. So and finally, we performed just simple linear regression models to adjust follow-up utilities for baseline utility. So missing data. So that's sort of the biggest problem here with the SF-12 data. So and to put some numbers around this, I think combined across the groups, there are probably somewhere around 4 patients with missing data at baseline for SF-12, and this could be partially completed surveys or completely omitted surveys. You know, and there are around, I want to say around 15 or so patients at follow-up across the 2 groups combined that have missing data. So Our approach to this was to use a multiple imputation method. So because we were imputing multiple characteristics, so specifically the responses to the survey, we used the multivariate normal imputation model. So multiple imputation essentially is a simulation-based method that allows you to account for, or essentially simulate what missing data would be using the observed characteristics. So using the data that you actually have. And it's based on, again, this particular model is based on a multivariate normal posterior probability model. And the key assumption is that the data that are missing at random, which is to say that they're missing at random conditional on the observed data, and they're conditionally independent of the unobserved data. So it's a really neat technique. I mean, there are just all sorts of really nice things about the technique. People have different ways of dealing with missing data, and just sort of overall, and generally speaking, it's a more efficient way of dealing with missing data, which is to say that the variances of your estimates are smaller, and it's also a less biased way of dealing with missing data. So there are a lot of really great properties around the multiple imputation method. So because it's based on a multivariate normal distribution model, it doesn't sort of spit out integer values, which is how the SF12 is scored. So we constrain the values by just rounding and constraining them to the ranges of the SF12 responses, if that makes sense. And that sort of thing has been done before. So finally, we calculated cost-effectiveness ratios using a difference in difference framework. So essentially, differences within groups and differences between groups. So differences within groups between baseline and follow-up, and differences between the intervention and the control group. And with cost-effectiveness ratios, when you're using clinical trial data, everyone's thinking about how do we estimate what the confidence interval is of this cost-effectiveness ratio. So the way that's typically done is with bootstrapping. But the challenge is that bootstrapping is a really neat way of estimating what the distribution of a parameter is. So we're familiar with kind of regression models where the distributions of the betas, as we've been discussing, are easier, are more straightforward because they're based on a model. But cost-effectiveness ratios are a quotient, and it's hard to know it's not the case that the distribution of that parameter is the distribution of the mean. We're not a quotient. So bootstrapping is another simulation-based technique. So you start with your original data. So in this case, we're talking about cost-effectiveness ratios, but we could be talking about anything. So you start with your original data, and you resample your data with replacement, pardon me. So you don't sort of take one and leave and sort of take that one away. You take one and you stick it back in, and then you draw again, and you do that a bunch of times. So in other words, you can have repeated measures of different components from the original data. And then you take each one of these sets and you calculate your statistic of interest. And finally, you plot a distribution of that statistic of interest. And this simulates what the distribution of the actual statistic is. And it just, beautiful work has been done by a gentleman named Efron, is his last name, at Stanford, who's really built this theory. So it's quite appropriate for cost-effectiveness ratios from clinical trials. But the challenge is, we're doing this multiple imputation method and I think probably the most important thing about multiple imputation I forgot to mention, which is, so you're imputing the data and you're doing it multiple times. So you're essentially recreating a complete set of data, and you're just doing that over and over again. And then there are methods for combining estimates, and then the calculation you want to make, you make it on each data set, and there are methods for combining the estimates from each of those data sets. So the challenge that Yassine and I had fun thinking about was, well, you know, how do we bootstrap? We have incomplete data. How do we bootstrap and combine the multiple imputation? So we actually layered them one on top of each other. So so this was Yassine's suggestion, which was a great one. So basically, we bootstrapped from simulated populations. So we're doing the bootstrapping, and each time we're bootstrapping from a slightly different population because each population sort of has imputed components. So that was our approach. And when you do a bootstrap analysis, to have a good estimate of the distribution, you really need to do it about at least 1,000 times. And finally, you can imagine that so if you do this 1,000 times, you can imagine that your 95% confidence intervals are sort of the 25 here and the 25 on that end. So let's talk about some results. So here are the SF12 domain scores at baseline. So these domain scores are standardized with a U.S. population to a mean of 50 and a standard deviation of 10. So that's what these SF12 scores are based on, and these are baseline data. So each one of these domains is a product of that SF12 survey that we looked at a few minutes ago, and it's sort of a combination of different pieces of that SF12 survey. So, generally the populations are similar at baseline in terms of their SF12 scores. And notably, they are significantly lower than the US average, which is 50. So at 9 months. So the asterisks represent, the single asterisk is significant at 10% level, and the double asterisk is significant at the 5% level. So at 12 months, and these are adjusted values. So again, these are adjusted based on baseline SF12 domain scores and other patient characteristics. So at 12 months, only physical functioning was significant at the 5% level, and mental health was significant at the 10% level. And something to keep in mind is that this study was not powered for detecting these types of differences. So it's something just to keep in mind in terms of what we're picking up. And then looking at the SF12 component scores. So these are summary measures of the SF12. So instead of looking at these 8 domains, you can actually just look at these composite measures of physical and mental health. And there are some weaknesses with their composite measures. Which is part of the reason that I sort of showed the domains. But here, only the physical component summary score is significant at the 10% level. So again, these are the SF12 scores. So now turning to utility. So we talked about the regression equation that takes the SF12 scores and converts them to a utility on a scale from 0 to 1, even though the actual regression equation actually is bounded. Its domain is actually more constrained than 0 to 1. But here's health utility at baseline. So based on this regression equation, and that's what happens at follow-up. And here there is a statistically significant difference of 5%, and these are adjusted values. So this is again these are adjusted for baseline values. And then healthcare costs. So Columbia is still sending us some data on the cost. So right now, we have up to 6 months of data that are still being cleaned. What I'm presenting here are 2-month data. So first of all, what you can see is that the hospitalizations are just much more frequent in the control group, and that's really amounting for a big part of the difference. At the same time, the mental health visits are again pre-specified in the intervention group and accounting for a big component of the cost in that group. And earlier we talked about how we didn't have count data for these outpatient visits. We only had binary data in terms of whether a patient had a visit or not. And so what I've done at 2 months, for everyone that said they had this type of visit, I just assumed it it was 2 visits, so a visit a month, just to sort of be able to do something. So, so there you're saying it's a smaller component, and there's actually a lot of comparability between the 2 groups. But really, hospitalizations are driving big cost differences.
And, sorry,
Yeah.
can you again define hospitalization? So it's number of cardiovascular, number of
Yeah.
ACS hospitalizations plus whether or not they answered yes?
So that, the count data there is accurate.
Okay.
So those were all
Just for
adjudicated.
cardiovascular,
Yeah.
Which is for cardiovascular.
Yeah, that's right. That's right. That's right. Again, these are based on uncomplicated MI costs. So one could think about if one had concerns about high users or outliers really driving this. I haven't seen this done before, but one could think about a log transformation of the cost, or potentially excluding them from the analysis. And that actually should probably be a component of the sensitivity analysis. So finally, the cost effectiveness. So again, these are bootstrapped on multiply imputed data. So so again, sampling exactly what we've seen, these cost data at the patient level and the utility data at the patient level. So what we find, and again, the costs are up to 2 months, the quality adjusted life years are at 6 months. So this is just preliminary. But what you're seeing is that most of the cost difference between the 2 groups is negative, and it's almost certainly driven by the difference in hospitalizations. And the quality of life difference, and because it's at 6 months, we sort of multiplied the difference in utility by half. So the quality of life difference is somewhere around 0.02 qualities. There's a little dot here that didn't show up, but it's the center, and it's somewhere around there. So the average change in costs is negative $700, so a cost savings of about $700. And the change in qualities is about 0.02 in 6 months. And then in terms of the 95% confidence interval, so you can imagine this is a little bit easier. You can imagine that almost almost all of the points really lie within here. And in fact, I don't recall offhand, but essentially, even at the 95% point on either end, the intervention's cost saving with the data that we have so far. So how does this compare to other interventions in patients with acute coronary syndrome? So this is what one of the premises, I think, for thinking about cost effectiveness analysis in this population. So it's hard to beat cost saving. That's a tough bar to beat. So if in fact that proves to be true when we sort of complete our data and stands up to sensitivity analyses, that would be great. Other interventions in this population, so beta blockers, Catherine Phillips at UCSF has looked at that, and they're very high value. Smoking cessation, I've looked at that, and that's relatively high value. The statins are also high value in this population. So there are a number of, what I didn't list on here are low value interventions in this population, but in terms of thinking about what potential comparators could be, I think it fits well within that. And intuitively, I think it actually makes a lot of sense. So in terms of next steps, we'll complete the analysis of quality of life and cost and complete our data. We'll do some sensitivity analyses of the imputation methods. Karina submitted a grant for a larger clinical trial of enhanced depression care, and it was sort of submitted before my time coming here, but potentially we'll be working together in the future on that. And really a translation of clinical guidelines and policy. So if we find that there is a difference, that we can really make a difference in patients who are persistently depressed after their heart attack, there's potentially a lot of good that can be done. So hopefully that's, if indeed we find that, hopefully that's down the road. Thank you.